Yorkshire Humber AHSN's overview of atrial fibrillation and oral anticoagulation. I'm Pete Waddingham. I'm a programme manager with the Yorkshire Humber AHSN. We're joined on the webinar today by Caroline Dixon, who's going to give a presentation in a short while. Caroline's a pharmacist at the Moorside practice in Bradford, and is also the clinical advisor to the Yorkshire Humber AHSN, and has over 12 years experience of anticoagulation and AF. And also we've got a couple of other colleagues on the webinar who will be on hand at the end to answer any questions. Okay, just a little bit of really brief housekeeping first. If you don't want to get reverb on this call, please just mute your microphones. Microsoft Teams has probably done that automatically for you. We are going to record this webinar just so that we can disseminate it to people that haven't been able to join us today. We've just put some privacy policy information on our website that you can check out. Because it's been recorded, if you don't want to appear on camera, then either put your camera off. If you don't want your voice to be on the recording as well, you can ask questions in the chat box function, or if you don't want to do any of that, you can also ask us questions outside of this webinar, and we'll be happy to help. And also there's a basic contact details form that we'd like you to complete at the end, please, just so that we can find out where people have joined us from today. Okay, really briefly, who are the academic health science networks? Well, there's 15 of them up and down the country. We're the Yorkshire Humber AHSN. We're a network of networks, and very briefly, our role is to try and find and spread innovation throughout the NHS. And we're involved in lots of different projects. So today we're going to talk to you about AF and atrial fibrillation project. But we're also involved in other CVD projects. We're involved in musculoskeletal projects with escape pain. We're also involved in a number of prescribing and medicines initiatives, as well as getting involved in the tech agenda and the digital agenda. So I wasn't going to go into too much detail in this webinar, but just a bit of a plea. If you're interested in finding out more about the AHSN, in particular the Yorkshire Humber AHSN, do have a look at our website. Details are at the end, and do follow us on Twitter. Okay, the atrial fibrillation programme was a national programme that came from NHS England, and the Yorkshire and Humber AHSN, as well as the other AHSNs up and down the country, were the delivery partner for this. And the programme was split into three areas: detect, protect, and perfect. So detect, there was a device which we'll show you in a minute called the AliveCore device, and that's a little 2-lead ECG. Also, once people had been found with AF, the aim of the project was to try and protect them with anticoagulation. And then the perfect arm of the programme was obviously to look at the optimising of that anticoagulation, which Caroline Dixon's going to go into in a little while. So our support as an AHSN, what we've been doing is we've been working with GP practices all over Yorkshire and Humber, and we put this under a quality improvement initiative, and we've got lots and lots of resources. And again, today we didn't want to go into too much detail because the aim of this webinar is to talk to you about some of the clinical side of AF and anticoagulation. But just we offer practice training that people can do online to help them with quality improvement, and we've got a platform that if people want to embrace the methodology of quality improvement and to look at AF and anticoagulation as a quality improvement project, we've got the resources that allow you to do that. We also can come and share with you some of the great best practice that we've seen all around Yorkshire and Humber, and again Caroline will share some of that with you. And finally, we've got the AliveCore devices, which you can just see on the right hand side, a little 2-lead ECG, which is a brilliant little device, and it helps people find those with undiagnosed AF. There's lots of other resources, and again, we wanted to keep this fairly simple, so please do get in touch with us at the end. We'd love to come and visit you in your practice, and we can talk through a little bit more about our support as an academic health science network for you in primary care. So next, I'm just going to hand over to Caroline Dixon. And as I said, Caroline is a pharmacist. She's got over 12 years of AF, and she's the perfect person to do this webinar. So thank you, Caroline.
Hi, everybody. As Pete's introduced me, I have quite a lot of experience in anticoagulation, but I'm more of a practical person. So my talk today is going to be on the practical side of anticoagulation rather than more of the research-based side. I joined the AHSN in 2018 and got involved with the AF project. And I'm also doing virtual clinics for Bradford City CCG as well. So the way I want to run the presentation is to start with the practical ideas. So starting anticoagulation, what do we need to know? Thought a basis on a case. This lady came to see us about 2 or 3 weeks ago. So she's called Mrs. Emmy. She's an 83-year-old female and she was newly diagnosed with AF. Her AF was found while she was in hospital for the treatment of esophageal cancer. The diagnosis was written on her discharge letter. As heart rate raised, ECG showed AF with fast ventricular response. She'd actually been sent home on bisoprolol 1.25 milligrams daily and aspirin 75 milligrams daily, but she'd had no mention of oral anticoagulation and she hadn't been told anything about her diagnosis of AF. The GPs at the surgery asked me to speak to her, but what should I say and how would I do it? With all patients, when you start prescribing medication, I think the most important thing is to try and empower them and make them want to take the medication. Because with all the will in the world, whatever we prescribe or recommend for a patient, it won't work if they don't actually take it. Especially with anticoagulants, where perhaps they've heard that warfarin is a rat killer or rat poison. It really isn't going to help the situation. So the sorts of things that we need to discuss with Mrs. Emmy. We need to try and understand what she understands really about her diagnosis. At the moment, it's probably very little. And we need to explain to her what that means in terms of a risk factor for stroke. AF increases the risk of stroke by 5-fold. And 20% of all strokes are caused by AF. She might have heard of this herself and she might have come to you with a real fear of what had been found and what that meant to her. So we need to address her fears and emphasize the positive fact that we've actually found this AF and that we can actually do something about protecting her and help reduce her risk of stroke. This happens in quite a few patients that I see, and I really feel that we need to turn this round and make people leave our clinics in a positive frame of mind. We do need to ask if, at that point, whether she wants to go ahead with treatment, because she could still turn around and say, no, I don't want this. And I've had that quite a few times as well. We need to risk assess her. You've probably heard of the CHADS-VASc score. And for Mrs. Emmy, her CHADS-VASc will be about 3. Her age is over 75, which gives her a factor of 2. And sex being female will give her 1. So that makes her 3. Which gives her a 6% annual thromboembolic risk. We also used to have to do the Hasbled score. And for Mrs. Emmy, her Hasbled works out at about 4, which we'll go through later on. We need to talk about her lifestyle to get an idea of how she takes her other medication and when she takes that other medication. We have to explain the treatment choices available to her so she can have warfarin or a DOAC. That is the nice guidance. And we need to explain the pros and cons of both options. We need to ask her to choose which treatment she would prefer. We need to give her that choice and one that will fit in with her lifestyle. Once she's made that treatment choice, we can go through it in more detail, talking about the specific side effects, the timing of any doses, whether she needs to take it with her after food, whether it interacts with food, whether she drinks alcohol, and if there's any other drug interactions, what to do if she misses doses, and also what to do if she goes to the dentist or needs a procedure. Again, we need to confirm she's happy to go ahead at this point in time, because having got all this information, she might have actually changed her mind and perhaps want to go away and discuss it with her family and make a decision at a later point. We would then prescribe the chosen medication, provide her with a treatment booklet and alert card, book a follow-up appointment or phone call, and add a recall to the prescribing system. Again, we'll go through this in a bit. So while talking to Mrs. Emmy, I found out that she uses taxis to get to the surgery. She doesn't want to have frequent monitoring. She does take her other medication once a day. However, she doesn't eat breakfast every day, which is relevant. I know it sounds a bit funny, but it is relevant. She's had frequent trips to the hospital for chemoradiotherapy for the squamous cell carcinoma of her upper esophagus, so she's absolutely fed up with going backwards and forwards for doctor's appointments. And at one point she was having problems with swallowing and was actually choking. However, that has much improved now. But again, that's relevant for which medication we choose. She enjoys the odd bottle of wine and a sherry with her dinner. So before starting anticoagulation, what do we actually need to do? We need to get some baseline information from the patient. So we need some tests doing. We need her U&Es, full blood count, LFTs, and a coagulation screen. We also need to know her blood pressure, her weight, and we need to calculate her creatinine clearance using Cockcroft and Galt. Other checks, we need to check for contraindications and drug interactions. We need to counsel her on compliance, on any side effects that might be going to happen, how or when it should be taken, like with or after food. And she needs an alert card and information booklet. We then need to gather the results. So for Mrs. ME, her blood tests were in range. Her serum creatinine was 50 and her creatinine clearance was calculated as 58 mils a minute. Coagulation screen was normal. Blood pressure was pretty good, 132/72, and her weight was 52 kilograms. So which anticoagulant should I use? We need to go by patient preference, obviously with our help to explain the different agents she could have. We need to think, can compliance be guaranteed, or do we need to help that in any way? We need to see if there's any contraindications to using any of the anticoagulants or DOACs, such as the renal function or whether there's any drug interactions. And we need to see if she wants once daily or twice daily dosing. Just a quick reminder here of the differences between warfarin and DOACs on a simple scale, really. If we start using warfarin, we're going to have a very slow onset of action. The dosing is going to be variable. She is going to have to come backwards and forwards several times and have monitoring appointments. She will have to be more careful with the food she eats, and there are many drug interactions, as we know. Sort of on a positive point, I suppose, that you have more leeway with missing doses, but the INR will drop, and we know we can reverse it. With DOACs, though, we will get rapid onset of action, mostly a fixed dose, obviously dependent on renal function. Rivaroxaban needs to be taken with or after food, hence the breakfast question earlier. There are a few drug interactions, and it isn't a fire and forget at all. We do need to monitor, but the monitoring isn't as often. There's a short offset of action, which means if they do forget a dose, they won't be protected, and they need to understand that. And reversibility is possible with dabigatran and some of the Zabans. So when would we consider using a DOAC over warfarin? Again, this would be patient choice. If the patient was already on warfarin and they had a TTR, time in therapeutic range, less than 65%, we would also need to consider changing to a DOAC, because being on warfarin, which is out of range most of the time, is more dangerous than being on it at all. Not being on it at all. Adherence is essential. So if they need a DOAC box, they can't use dabigatran because that can't go in a DOAC box, whereas they can have rivaroxaban, apixaban, and adoxaban. Dabigatran has its own DOAC box, which may or may not make things easier for the patient. There is no first-line choice. We need to look at each individual patient and weigh up the options. This cartoon was meant to be showing that basically the warfarin does work, but only if you take it, and also that obviously this chap's giving it to the rats, so it's working in the rats, but it's causing a subtherapeutic INR because he's not taking it. So just decision time. Mrs. ME chose a DOAC. Her adherence is good, she says, but a DOAC box might help her compliance. Creatinine clearance was noted to be 58 mils a minute, and all her other medication is once a day. So what was the shared decision? We actually went for edoxaban, 30 milligrams once a day, and this was based on her creatinine clearance, the weight, the frequency of dosing and monitoring, and the patient lifestyle. So edoxaban full dose is 60 milligram once a day, and you'd use that dose down to a creatinine clearance of less than 50 mils a minute. So in theory, she would be fine on 60 milligrams once a day. However, her weight was 52 kilograms, and at 60 kilograms or less, we need to reduce the dose to 30 milligrams. We went for a once a day dose because that would go with all her other drugs that she takes. And the frequency of monitoring would be less than with Warfarin. This drug would fit with her lifestyle, so hopefully she would actually take it. So what next? As I said before, prescribing a DOAC isn't fire and forget. We need to actually review the anticoagulation as we would do with Warfarin, etc. So at points along the line in the future, she will need her UNEs checking so we can calculate the creatinine clearance. Now the frequency of monitoring will increase as the creatinine clearance decreases, or if you get near to a dose change. We need to check full blood count, LFTs, BP and weight annually as good practice. Also check that there's no new contraindications come up or any drug interactions. All the way along the line, we need to check compliance and also ask about side effects. Everybody does their recall intervals differently, but as a rule of thumb, if you take the creatinine clearance and divide by 10, it gives you a rough idea of how often, how many months should be in between the UNEs. So for a creatinine clearance of over 50 mils a minute, we could check annually, although we normally check about 6 monthly. 30 to 50 mils a minute, we'd check 3 to 6 monthly, and less than 30 mils a minute, we'd check 1 to 3 monthly. And we would consider monitoring earlier if there's been a sharp decline in creatinine clearance. And certainly as it goes down to 20 mils a minute and less, then we might even do it monthly. So for our case, Mrs. Emmy started taking edoxaban 30 milligram once a day in the morning with her other medication. She decided she didn't need a DOAC box after all, and she was really good at remembering to take a medication in the morning anyway, and the tablet we'd chosen, medication we'd chosen, hadn't affected her daily routine. She did actually stop the aspirin and took the edoxaban instead. She was given an alert card and a booklet on AF and edoxaban, and she was booked in for a follow-up phone call with me a week later to also discuss any GI problems, for instance, gastroirritation, and then we could offer a PPI if necessary. She was added to the recall system at the surgery, and she was to have UNEs checked in 6 months and an annual AF review to include UNEs, LFTs, full blood count, BP and weight. This slide was just to remind me to let you know about some other clinical systems and pathways that we have that might help you. We've developed some pop-up templates which can be installed on System 1 at the moment. We haven't used it on EMIS. And these will pop up when a patient enters the surgery and their consultation is opened. And if they haven't had a pulse check in the last 12 months, it will remind us that we need to do that. It will also suggest that we perhaps check the pulse using the AliveCall monitor that Pete mentioned earlier. And then you can go, if AF is found, you can go to the template which will help you code and then follow up the AF in the future. Search-wise, we tend to use the QOF data, and we look at the patients who have got AF but haven't been treated. Maybe if they've got a CHA2DS2-VASc score of over 2, it comes up in the QOF data that they haven't been treated, they're missed patients, so we can concentrate on them, as well as obviously detecting new patients. And in the pipeline, we have a guide to the management of AF, which is based on the one done by Matt Fay in Westcliff Affinity Care. and that will help guide GPs through what to do when they find a new patient with AF. Thank you. And if there's any questions, I'll be happy to try and answer them.
Okay, thanks for that, Caroline. I think what we'll do is we'll make sure that we make the slides available to everyone, and we've got our contact details that people can get in touch. And as we said earlier, we would love to come and talk to you in practice. So please do get in touch with us using the email address on there, info@yhahsn.com. And then we can spend hopefully a little bit more time with you, explain the projects that we're involved in, how we can support you. And I know Caroline's only more than happy to keep taking questions, so we can find out some of the things that you're interested in and share the resources. So thank you for joining this webinar. I hope you found it of use, and yeah, thank you, Caroline, for an excellent presentation, really covering a lot of your expertise that you've gathered over the last 12 years. So thank you very much for that.
Thank you.